Good afternoon, and thank you for attending our Spark TS webinar today, Drug Testing, Knowing Your Numbers. Today, we're going to be coming up with strategies and things that you can look for when you are putting together your testing program for 2024 and beyond. We get started though, we're going to talk through what we are as a TPA and what our services are. At Spark TS, we are a full service lab and MRO. We do random pool management and selection. Additionally, we assist with company and DOT compliance and policy development. We are also a full collection facility where we have clinic and on-site testing throughout the United States, with over 4,000 clinics, and we do electronic ordering and document management. And we're most famous for RailTasker. RailTasker DAT is our software solution for drug and alcohol program management so that you can have a strategic program and be paperless at the same time. Our executive leadership is Katie Enue. She is our, and I am the Vice President of Drug and Alcohol Programs here with Spark TS. I am also the speaker. I am a CEP, a DOT substance abuse professional, and a DAC, and also a certified drug and alcohol collector trainer. We're here to talk about your role. What do you do in your role as the DER? The DER is actually defined in 49 CFR Part 40. This is right out of the regulations. I didn't make this up, but the DER is authorized by the employer to take immediate action to remove employees from safety-sensitive duties that cause employees to be removed from service and to make required decisions in the testing and evaluation process. The DER also receives test results and other communications for the employer consistent with the requirements of Part 40. Service agents cannot be DERs. Spark TS is a service agent. We can't be the DER for you. We can provide you with resources to make your job a little bit easier. This is a DOT regulation. If you're not covered under DOT, you can also do this as a company regulated drug and alcohol program manager. The strategies we're going to talk through today are for any regulatory mode or non-regulatory mode. There's a lot of interesting things that we'll bring up today. And I spent about 20 years as a DER in different agencies or different companies. And the biggest thing about being a DER is you have to be a part of your organization. You also need to understand your business obstacles and be familiar with your numbers. And that's where we can look at our year-end numbers, like your statistical summary reports that you get from the lab, your MIS reports that you'll get when you take your overall snapshot of the prior year. Some people also take a look at the last 6 months. If you're a FRA regulated contractor, you are probably having to do that for your railroads every 6 months. Another thing that I've added in is also the usage of your referral programs under your EAP. Those are things to look at that we'll walk through today. What I have here is a snapshot of a statistical summary report. Now, just to take a step back, a statistical summary report is a report that the lab provides to you with lab reported results. These results are not reviewed by the MRO at this point. If somebody does a downgrade, so if somebody has maybe, if we look here, we've got 3 amphetamine positives. This is a situation where those 3 amphetamine positives, donors may have had a prescription for them, and this actually on your MRO report looks like a 0. Again, these are numbers from the lab. But I think it's really important that you take a look at your statistical summary for many reasons. Number one, does this data match your other data? If you look at your statistical summary, and I will break this down a little bit more, but you see here I have 7 marijuana positives. Did your MRO report 7 marijuana positives to you? If you didn't receive 7 marijuana positives, there is a breakdown somewhere. this is a great place for you to go in and see what's going on. And your lab will also break this down for you for company authority or your DOT agency mode or different accounts that you have. I have clients that have different accounts, maybe have 3 or 4 different accounts under their company. Maybe they're doing non-DOT testing without marijuana in one panel. Those reports can come out differently. But let's take a look at what this is. But it's really important to really take a look at this as an overall look of your program. First of all, here's a look at our pre-employment testing and just a snapshot of all of the testing events that we did. Here, I did 129 pre-employment, 2 post-accident, 15 randoms, 21 reasonable cause, 5 return to duty, so on and so forth. Let's just say that you are a FRA company and you look at this and go, oh my goodness, 2 post-accidents. Those aren't going to be the post-accidents that are reported to you by the FRA or the Chesapeake Bay Laboratory or your MRO. This somebody went in and actually probably marked post-accident on the form, on the chain of custody, and it got put into your system as such. You're going to want to make sure that this is a situation where it went to the lab, but maybe it got changed at the MRO, but didn't get changed at the lab. These are things to look for. Additionally, if we go to the next slide, on the next slide, we can see our total samples that were reported out as negative or negative dilute. A lot of people ask about these negative dilutes, and if you get in here, oh, there's George's dog. If you go in here and see that you have a company and maybe you have 20 negative dilutes, it might make you think, okay, what's going on? Why do we have so many negative dilutes? But if you are in Texas and you're working in the summer, and what are you doing in the summer? You are outside working in the heat and you are telling your employees, drink liquid. Maybe that's why they're diluted. But like I'm here in Minneapolis, if I had 20 dilutes and a lot of them happened in January, you know that there might be a problem, that somebody might be trying to dilute a sample. Maybe you have a group of employees that are very athletic in that situation. But dilutes are one thing to also look at, how many dilutes you have. We'll go to the next slide, please. Now we're going to look at how many samples were rejected. Here's where we've got fatal flaws or uncorrectable flaws. This is also a look at how your collectors are doing. In this situation, you've got 3 tests that could not be corrected and they were fatal flaws, so those tests actually had to be canceled. These are situations where you needed a negative result in order to proceed to the next process, maybe like a pre-employment. You need a negative pre-employment, right, to go on and offer that person or put them into regulated service or DOT service functions, or maybe the return to duty test. This is a place just to really look at that. And then you'll want to make sure, hey, those 3 fatal flaws, did they complete the proper error correction training if they are DOT regulated? You'll want to take a look at that with your collectors. Next slide. Now here's I don't want to say the fun stuff, but this is where you can go in and look. And now here we're looking at your samples for positive testing. Again, in this situation, we've got marijuana. We had 7 positives. There shouldn't be, under a DOT regulation, a downgrade for marijuana. Maybe if you're a non-regulated employer, you remove that from your panel. You might not see it on your statistical summary. Or maybe you say, yeah, if you have a med card and it gets downgraded, you might see 7 here and 3 on your company report. But if this is just a great place to look at what's happened. Now, as an employer, a place you could really look at if you were interested, you could look at the prescription drugs. We could go back to the opioids here. In this situation, there's not a lot of opioid non-negative lab results. Let's just say we go in here and we look at codeine, and maybe there's 13 codeine positives, and maybe what was reported to you was 2. You might want to figure out why. Do we have an issue with codeine, or do we need to do some education to make sure that when people are taking prescriptions that they're using it so they can safely perform their job? Another thing to look at too is the number of safety advisories and MRO letters your MRO is sending you after they test for a prescription drug. If your MRO is not sending you out safety advisories and you're looking at your prescriptions going, holy smokes, what's going on here? And your MRO is saying with this prescription they can safely perform their job, it might be an opportunity for you to take this report, take it to your MRO and say, let's talk through this, what's happening. Because you won't be able to see those laboratory results if you are a DOT employer. If you're a non-DOT employer, you could, but it's just something to take into consideration in regards to medication. Let's go to the next slide. Again, here is the number of samples that were reported adulterated, substituted, or invalid. That would show up on here. Again, it's not going to say refusal because the laboratory does not make a test of refusal to test. That comes from your MRO or the DER. But this is a great way for you to go in there and check that out. That is our statistical summary. Just as also I forgot to say this at the beginning, if you have questions, please drop them into the question box. Georgia will help provide those questions to me. Our chat feature, we don't have that turned on, but if you've got questions, go ahead and put that right into the question box. I know I might be going fast, but please feel free to put that information in. What we're looking at here is now a statistical summary. This is what's happened in your organization over a certain period of time. This actually is a statistical summary for the last year. What this is doing is providing me a snapshot of all of our testing. And this can be auto-generated from the reports that you may have, or with our system, you can pull an export of all of the data. And I always say just create a pivot table and boom, that information can go right into the MIS report. But this will show you what's happened in the last year. And in this situation, we have, I think, 260 covered service employees. And just because you're not an FRA regulated employer doesn't mean you can't do an internal MIS report. I encourage you to take a look at what's happening in your company. See how many employees you have, do the numbers, do the math, make sure that everything is looking proper when you go through your MIS report. Let's take a look at this MIS report and see what we can find. The MIS report is going to break it down into drug testing data, and it's also going to break it down into alcohol testing data. This data here is the number of tests that you had in each category. So in each DOT category, it has that. And then the number of positives and where those positives occurred, and the number of refusals and why they were refusals, and the number of canceled tests. In this situation, we'll keep a couple of things in mind. We have 260 employees, and let's say we're testing at a percentage of 25%. If we're testing at a percentage of 25%, so I got 260 divided by 4, we're looking at we should have 65 randoms 65 random tests for drug and alcohol if they're doing that 25%. I can look at the pre-employment. We have 110 pre-employment results. 92 were verified as negative. You can see we had 16 verified positive results. In here, you can see where those results occurred. It looks like maybe cocaine and marijuana and amphetamines were the big places where the testing occurred. In this situation, I might go in even and look and say, is this amphetamine or methamphetamine? Maybe dig down into those 4 positives to see what they were positive for. Is it positive for a prescription, or is it really the meth that's made in a garage or house somewhere? Those are things to look at in your pre-employment testing. I want to sneak to the next one really quick, Georgia. We're going to sneak back and forth. In this situation, we're going to, at the pre-employment level, I also want to look at this. This is the alcohol test. We had 2 alcohol tests that were completed. If you're a DOT employer, you're either going to do alcohol testing for all pre-employment tests or none, right? Some don't even allow it at all. In this situation, I'm going to go, why did we have 2 pre-employment alcohol tests? If I was doing it for everyone, I should have had that, 110 like I did before. That's something that will pop out on the MIS report. We'll sneak back to the previous, Georgia. Now we look at the randoms. We know that we could have 65 randoms, right? Because that's our 25%. Here we're at 75. And we can look through and go, okay, what's going on here? You can say that I've got the 3 positive results, 2 are for cocaine, 1 is for opioids. And you can go in here too and go, oh my gosh, I had 6 shy bladders. And that was a situation where I was in one point, I had a client that had several shy bladders. And so we talked through what we could do. They were legitimate shy bladders. How do you get yourself out of that situation? We walked through different strategies on how to do that. We'll talk through that later. This is post-accident. Maybe this is a company that doesn't do post-accident under DOT, like a railroad doesn't have DOT post-accident. They have FRA-related post-accident, not under the urine panel. Also, this is where you can look at your reasonable cause, reasonable suspicion. If you have that on your testing program, you can see, is it effective? If you go in here and look at this, we have 19 reasonable cause or suspicion tests, and of that, 15 were negative and 4 were positive. That's a pretty high positive rate for reasonable cause, reasonable suspicion. For example, I would also take a look at, like, FRA is specific. FRA says you either do DOT or non-DOT testing in certain situations that occur. If you're a client or a company that does all non-DOT testing, and you go in and find out most of your percentage of your positives are covered service employees under reasonable cause testing, that might be an option to go, maybe I need to consider doing federal cause testing because that impacts certification down the road. Things to think about, but that 4 verified positives out of 19, in my opinion, is quite a bit for cause testing. It has return to duty and follow-up testing in here. Again, follow-up testing is another one to look at. How is your relapse and prevention programs going? If somebody's on a follow-up program under DOT, they've had a DOT violation. If it's not under DOT, maybe it's under company authority, you can check and see how those programs are going. In this situation, we had 7 follow-ups. Maybe that was one individual. You could look deeper into that. All right, we can go to the next. Or actually, we've also got canceled. We also have the canceled test results on the drug testing. If you've got 4 test results, you're going to want to have that documentation why those tests were canceled. Because if you are audited under DOT, they're going to ask for that documentation. And if they were canceled and recollection training was required, that would need to occur. All right, we'll go to the alcohol testing data. We're going to look at the similar things here. I would look at your random testing. Things to look at in random testing are the number of screening tests that we have. Everything should be below a 0.02, right? If I have a screening test that is greater than 0.02, so let's say I have let's just say this number is 5 in the results of 0.02 or greater, and my confirmation test with results was 4. Then I know I had a test that went from above a 0.02 to below a 0.02 because that confirmation test is not correct. If there's a substantial difference in that, you might want to take a look at what's happening in your program there. Additionally, we go through how many test results were at a 0.02 to 0.039, and then the ones that are a 0.04 or greater. I do think it's very important to know what's happening with your positive results. I think I would even drill down even deeper and look at when these tests are occurring, when are the positive tests happening, and additionally, how many of these are happening at the beginning of the shift, end of shift, so on and so forth. Now we can look at the reasonable cause testing. Again, 19 of these, and 2 of them had confirmation results of 0.04 or greater. Unfortunately, this does not break down cause versus suspicion, but in this situation, you can see that we did have 2 positive tests. We also have the return to duty testing in here. Here's actually where we have a screening result below 0.02 and nothing with a confirmation test. And then our follow-up testing is in here as well. Georgia, can you flip to the next slide? It looks like we have a dispatch. We also have, she must be dispatching a call right now. So.
Hold please, everyone. Just a little bit of technical difficulties.
Now, you're good.
You can hear me now? Okay, that was weird. Sorry. I apologize for that. With random testing, again, you're going to want to check when are these people being tested. You can also go in and look at what time of the shift they're tested. Are they tested in the morning, like at 0900, or are they being tested? I mean, if you're a 24/7 operation, you should have tests in the middle of the night. You want to really get into when this testing is occurring. Additionally, alcohol testing. This is an important thing to look at because if you're looking at alcohol testing, you're going to want to look at the number of positives that you had and that test result. And I went over that briefly in that test report. If you have 5 tests that drop below a 0.019 or 0.02 that were screening, and so you didn't get a confirmation test on them, I might ask myself, why did that happen? And I might go in and look at those. You might find out you had somebody that had a 30-minute wait. Why'd they have a 30-minute wait? Or you might find somebody that has been on duty for 2 hours and then they were tested. What if you would have tested them 30 minutes earlier? You could have had a positive test. Not that we want to capture and have all these positive tests, but your job is to keep your company safe. So that would help you ensure that you have a safer environment. Additionally, look at the time these tests occur versus what time the shift starts. In my past experiences, a lot of alcohol positives happen at the beginning of the shift. And could be a situation where you have a collector come on site, the person goes on duty at 0700, the first test is at 0710, boom, then you've got an alcohol positive. But if that first test isn't until 9:40, then you may have lost that positive test because of that, maybe a commute to a collection facility. Maybe they needed to go through briefings or all these other things. But it's very important to think about what would happen if you did testing immediately at the beginning of shift, if you already are not doing that today. Not 2 hours in, I'm talking right when they walk in the door and they begin their day. We'll go to the next slide, please. Random pools. This is another thing to look at. Now, this is outside of that MIS report. When you are doing your random testing, take a look at your pools. If you have 2 small pools that you're running with 10 employees in each, and you're testing at a 50%, you're going to have at least 5, right? It might be a situation where you could combine the 2 pools. What you have to remember in that situation is that you're just testing at the higher percentage of employees. If your testing percentage for one pool is 25% and the other pool is 50%, then you're going to want to test, of course, at that 50%. You'll want to look also at maybe if you're in a consortium, if you've got 30, even 20 people in a consortium, you might want to think about having your own pool for that. If you have several pools and they're being managed by a consortium, maybe it's time you say, I want to have a pool for my own company so you can manage what's happening. I always say it's nice to know your people. So I would definitely encourage, if you have several people in a pool, that you have them in your own pool versus consortium. Now, that doesn't mean that your TPA doesn't run that pool. It just means you're not in pools with, or a random pool with, other companies. It's all your company. Again, look at numbers of employees. Other things to look at is quarterly versus monthly testing. If you have 12 employees and you're testing quarterly, it doesn't take a rocket scientist to figure out 1 test a quarter, right? I would strongly encourage looking at how your testing is getting done. You have to understand, our employees are smarter than we give them credit for. Make sure have the numbers to do the testing. Just be really smart about how you're testing. If you have 300 people and you have turnover, quarterly testing is probably not the right type of testing to do. Monthly testing might be the right thing to do. Make sure you understand your actual employee base. Other things to look at in your random testing pool is, why aren't testing events occurring? Are testing events not occurring because you send out a notice to the managers at the beginning of the month and then they forget about them, and then you have to remind them at the last day of the month, and then none of the tests are getting done? Maybe those are things, if that's occurring, maybe as the DER, you're breaking up tests yourself. So you're saying, these people I want tested week 1. Then you tell your managers, or you assign those tests week 1. Then maybe you have another group for 2, so on and so forth. Be strategic. All of these tests are evenly distributed throughout the entire month or quarter, however you're testing. We'll go ahead and go to the next slide. Other things, and this kind of goes back a little bit to that alcohol testing, clinic versus on-site. What I mean by this is, a clinic collection is actually a brick and mortar building. You're taking your employee, or you've instructed your employee to drive to a facility to do that test. An on-site is where you actually have a collector drive to your location, do the testing at the location, and then drive away. Really, you've got them captured in one spot. With clinic testing, how long is it taking your employees to get to the clinic if they're driving on their own? And how long is it taking your supervisor to get there? Things to think about, and just weighing the pros and cons in that regards. With clinic testing, sometimes I'm still surprised at the number of employees that aren't escorted to the testing site. Again, that's just a preference. You don't have to escort them. You just have to give them notice to the testing site. And how much notice are you giving employees prior to testing? The regulations say that they must go to the testing facility immediately. Immediately isn't 4 hours or after a report is completed. Immediately means, hey, you've been selected for a random. You need to immediately go to this collection facility and provide that information. And I know the next one we don't want to think about, but how much notice is your supervisor given prior to testing? Is it a situation where are you giving your managers notice, and maybe their friends or peers or whatever they might be, is information getting trickled down to the donor so he can study, or she can study for the test, which I mean pass the test or cheat in the test? Maybe it's worth saying, hey, this month I'm not going to tell any supervisors about their testing. I'm just going to go ahead and say, you need to do a test on this person today, giving them very short notice. You can test and see how that works out. Maybe you don't have an issue, but those are things to consider. We'll go to the next slide. Unusual testing events is another thing I think it's important to look at. The shy bladder process. Talked a little bit about this in the beginning, but if look at your numbers at the end of the year, and you had 10 events that resulted in a shy bladder. Why did they result in a shy bladder? If you would have given them 5 more minutes, would it have been a shy bladder? If you as a DER would have been involved, would it still been a shy bladder? Maybe. Or how many people, and I'm meaning more like not a legitimate shy bladder, but those that maybe ended in a refusal because they didn't have a valid medical explanation. If you can get involved in that process, maybe you have your collectors call you at hour 2. It might help with some of those numbers. Also, sometimes there's a misperception that people have 3 hours to take a test, and some of you are probably nodding, yeah, everybody thinks they get 3 hours. It's 3 hours of paid time. No, it's not. You still have to provide your sample. But if you have people chronically doing that, maybe at some point you need to be getting a call and reminding them that what their job is. It's not to sit there. They need to be following instructions and providing the sample. I also would take a look at your refusals. Why are your refusals happening? Sometimes people simply just walk out. People just say, I'm not going to do this. I didn't realize it, and they just walk out. Other people, those refusals, they might be occurring after the after the first attempt. Maybe the first attempt has come back where somebody has a cold or out of temp urine, and then they all have left because they're not going to provide that second sample like they're required to under the regulations or under company policy if that's the case. I would look at why, or people just blatantly saying, I'm not doing it. You're here to test me. I'm not going to be tested. Go fly a kite or whatever they're doing. Know what's happening. And as a DER, are you being made aware of the refusals? If you pull a report and all of a sudden you go, oh my gosh, I only know about 3 of these. Why do I have 6 refusals? Somewhere the line is broken. A lot of times when we find this too, is that sometimes the collector just says it's a refusal and doesn't tell anybody else when that collector should be picking up the phone and telling the DER, hey, Johnny is here. Johnny's refusing to provide a breast sample for me. I would like to give you that information so you can make a good determination on if this should be a refusal to test, instead of just writing refusal and sending the paperwork in. Those are really important things that I would look at what's happening with your refusal process. And then again, negative dilutes. When are negative dilutes happening? Are they happening for where is it a location like Texas? Negative dilutes probably will happen in the summer in Texas. And who are they occurring to? You might find that you have someone on a follow-up program that constantly has a negative dilute sample. Okay, maybe there's something going on. Maybe that person is still using or whatever they're doing and diluting that sample. You might want to have a conversation when you have that next test to immediately go to the testing location, not give that person any notice, and really just escorting them the entire time. Because if you say, hey, we're going to go for a drug test, and sure, no problem, I'll drive to the clinic now. In the clinic, they got 2 gallons of water. They're sure heck going to dilute that test, and it is going to come back negative. Okay, we'll go to the next slide. Another thing to look at is your pre-employment testing. Pre-employment testing is really your new hires. How are you bringing in your new hires? And I know we're in a really odd time with hiring. It is hard to find people. If you're doing alcohol testing and over the last 2 years, 3 years, 4 years, you've had 0 alcohol positives, it might be a situation where you say, do we need to continue doing this? I'm not telling you to stop doing it, but it might be a situation where you can determine, is this working or not working? Or maybe you want to try alcohol positives. Maybe you find that you have several random alcohol positives, and maybe you feel like you need to bring alcohol testing in. Also, there's hair testing. Hair testing is going to be testing for chronic usage of drugs. The urine will have that shorter window of time, but people are going and doing hair testing and going in to say, oh, yep, we're going to look over the past 90 days and how much has this person used. Are you doing hair testing? And if you are, is it effective? Other people are skipping that all, not even doing lab testing. They're going right to POCT testing, point of collection testing. And this is a situation where you go in, there is a immediate result of the urine. If the test is inconclusive, it gets sent to a laboratory and reviewed, and the final result comes out. A lot of people are doing that to get an instant negative result, but again, it's just a screening. It's not a confirmation. I also would have you think about return to work tests where you would have people that are returning back to work. Maybe they're returning back to work from being furloughed, or maybe they've been on a very extended leave of absence. Bring those people back to work. What's the result of their test? If somebody's out for 12 weeks, like in Minnesota, for example, we cannot, under Minnesota law, cannot hire or do a drug test more than once a year. You're looking at every 6 months, maybe, that the test is completed under a return to duty or a return to work test. Are you doing return to work testing? And notice I didn't talk about marijuana too much. Some states say you can't test for marijuana for non-regulated positions. Those are also things to keep in mind. I think the last thing I have is peer support. This is where knowing what programs are available to your employees to get help. It surprises me even sometimes that DERs don't know where to send people to get help, or people in human resources, or even managers. This is an opportunity for you to provide education to your teams. Some of the things are there's formal referrals. A formal referral can be somebody who self-refers and asks for help. It can be where you've got peer referrals, where people are referring other people that could be under the influence at work, or maybe a manager referral, where maybe they've determined that there is a situation that needs to be addressed and they need to go in and get the help. Those are things, if you're seeing 0 across the board and you have 1,000 employees, you might go, oh, yeah, you don't have a problem. Maybe your people don't understand that they have a problem or can get the help. Those are things to look through. What's your usage like? In EAP programs, your EAPs should be also providing you some sort of a statistical summary of the calls they're getting in. How many people are calling in to get help for drug and alcohol use? Now, you're not asking for names. This is all confidential. But if you're seeing a spike in that, maybe that's an opportunity to provide some education for drug and alcohol use in the workplace. One other thing I'd add to this too is with your EAP programs, and maybe your support would be your follow-up testing. How many of your follow-ups are coming back positive? If you've got a high percentage of follow-ups coming back positive, what's that relapse and prevention program looking like? Are people going in and getting help? And if they, quote unquote, fall off the wagon, do they know what to do? A lot of times, in my experience, when these things have occurred, it's because someone has maybe stopped going to AA, or they've lost contact with the people that are there to help them if something goes wrong, and they just decide, forget this, is too hard, I'm just going to drink, or I'm just gonna do whatever I need to do. Think about those things of what's going on in your program. I've done a lot of speaking. I was going to check to see now, Georgia, I don't know if we have any questions that have come up during the webinar.
So we do have a couple. I've got a question that asks what happens if after 3 hours an employee is at a clinic to provide a specimen, but they can't provide the specimen and the facility begins to close. What do they do?
Mm-hmm. If it's after the 3 hours, under DOT regulations, you have up to 3 hours to provide that sample and provide water. I would say if it's a situation, and I think this could go both ways, right? They've hit that 3 hours. Now they are going to have to go in and have a medical assessment. But it shouldn't matter if that clinic is closed, because they should provide the documentation. But I think what this means is, what if you have a clinic that you're in hour 1 and then they say, oh, we're closing in 10 minutes, you can't finish, okay? That's a problem with the clinic. Those are things that need to be addressed with the clinic. If you went to a Spark TS clinic and that happened, we definitely want to know, because that's not acceptable, because if you start the process, you need to be able to complete the process. What other questions did we have, Georgia?
Question about the scope of DOT drug testing, and if there's anything more that we could share about drug testing strategies for DOT testing.
And we covered some today. If there's more specific questions that you're looking at, just take a look at what happened last year. Make sure if you have 25% of your population is testing positive, you know that there might be a problem. Maybe you need to do more education. It could be maybe you even need to up your random percentage rate. If you have any questions, we'd love to be able to talk to you. You can email me directly at holly@sparkts.net. Thank you for participating today, and have a great day.